everyone, I'm Chenzhen Zhang, a second-year graduate student in a microbiology lab at Northeastern University. Here, I will be presenting my work on design and synthesis of cationic CT contrast agents for imaging negatively charged soft tissues like cartilage for early diagnosis of osteoarthritis. Osteoarthritis is a painful disease of the joints that attacks cartilage. Currently, there are no available treatments to treat OA. Patients have to take pain and inflammation relievers as long as they can and eventually get their joints replaced. Early diagnosis and early intervention of OA is therefore very critical. However, early diagnosis of OA is still not feasible. X-ray is the only FDA-approved method that relies on measuring the narrowing of the joint space thickness as an indirect indicator of cartilage health. But it's too late for intervention when X-ray can detect any significant changes of the cartilage. 3D X-ray and CT imaging can be an effective diagnostic tool using contrast agents like L-cyclic acid, LX. However, LX is a small molecule and thus is rapidly cleared out from the joint space. It's also negatively charged, and thus its penetration is repelled by the negatively charged matrix of the cartilage tissue. Cartilage comprises of a high density of negatively charged aggregates, glycosaminoglycans or GAGs, and collagen type 2 meshwork. The density of aggregates increase with depth into cartilage from the superficial zone to deep zone, confirming it a high negative fixed charge density and reducing the pore size to be in the nanometer range. Also, it hinders the penetration of most macromolecules. Therefore, the window of imaging after injection is short, and the high LX doses in the range of 100 to 400 milligram iodine per milliliter are required, which cause significant toxicity. As such, cartilage CT imaging is clinically infeasible. Our lab has shown that this high negative fixed charge density of cartilage can be used as our advantage by making drugs positively charged, such that they can rapidly penetrate through the full thickness of the cartilage in high concentration before getting cleared out from the synovial fluid. The high negative charge cartilage results in a decrease in the electron potential and having a strong inward pointing electric field from the synovial fluid to cartilage. We have shown that the optimal positive charge on the drug or drug carrier should be chosen to have high donor partitioning at synovial fluid and cartilage surface interface to facilitate high uptake and a rapid transport rate inside the cartilage. The binding should be weak and reversible so the carrier can penetrate through the full thickness of the tissue, but too high of a cartilage will result in too strong binding interactions, and all the solute will get stuck on the surface of the tissue, which is not ideal. So we developed nano-charged cationic contrast agents and demonstrated that they can achieve CT imaging at 32 times lower dose. This makes CT of cartilage clinical available for the first time. It also has high translational relevance as it is a diagnostic tool. The approval process will be much easier than drugs, so we can get these contrast agents into market much sooner. For example, our lab has shown that having a positive charged glycoprotein is an ideal drug delivery system that can penetrate through the full thickness of cartilage in high concentration because of the optimal size, about 7 nanometer, and the net charge, the isoelectric point is 10.5, but the neutral avidin has similar size with the avidin. The charge is neutral. As we can see, neutral avidin can only get stuck on the cartilage surface. Everything penetrates through the full thickness of the cartilage, results in about 400 times higher uptake ratio than the neutral counterpart. In animal study, everything was found to be present in full thickness of cartilage even after 3 weeks of following its administration into the knee joints of the rabbit post-traumatic OA model, which makes everything a very promising drug carrier. Based on evidence structure, we designed short-length engineering-rich peptide sequence, cationic peptide carrier or CPCs with net charge, with very net charge. We can see CPC plus 8, plus 14, and plus 16 can penetrate the full thickness of the cartilage in 4 hours, but CPC plus 20 can only stay on the cartilage surface because of the strong binding interactions. The uptake in cartilage does not increase monotonically with the net charge. CPC plus 8 shows the highest uptake ratio greater than plus 8, then plus 16, and higher than plus 20. In this work, we have used evidence and CPC plus 8 to design portably charged LX and used for cartilage imaging. We choose CPC plus 8 because it has a very high cartilage uptake ratio of 50. And more importantly, it does not stay inside the cartilage for a very long time, unlike other CPC peptide. It can dissolve out of the tissue within 24 to 48 hours, which is ideal as we want our imaging contrast agents to rapidly penetrate through the full thickness of cartilage in high concentration and then dissolve out for after imaging as well. Additionally, we have found that CPC plus 8 does not affect cell property even at high doses, which is important. Also, CPC plus 8 is not uptaken by the chondrocytes, and that is an ideal carrier of the CPC plus 8 for delivering contrast agent. For conjugation of LX with iodine, the carboxyl group of LX was converted to LC chloride using the cyanic chloride in DMF solvent at 70 Celsius degree. And then the intermediate product LX chloride is reacted with the H-arm PEG amine in DMF solvent with the addition of TA as a catalyst. The H-arm PEG LX was mixed with the iodine at 4:1 molar ratio in PBS to obtain the multi-arm iodine structure conjugated with LX, which we also call it multi-arm iodine LX. We achieved a high LX loading of 12 to 16 moles of LX per multi-arm iodine. As for CPC LX, the intermediate product LX DSC was obtained by reacting the hydroxy group of LX with the DSC in DMF. Then the CPC plus H peptide was mixed with LX DSC to synthesize CPC LX in PBS. Each CPC plus H peptide will have one molecular conjugated LX. We found that both multi-arm iodine LX and CPC LX resulted in about 40 to 80 times higher uptake ratio than LX alone, and no matter in normal or gag-depleted cartilage. Both cationic contrast agent multi-arm iodine LX and CPC LX achieved equilibration within a short period of time of 4 to 6 hours. Now let's look at the CT attenuation images. This is blank. This is LX at a very small concentration of 0.5 milligram iodine per milliliter, and we can see there's no significant signals inside the cartilage. However, when we use the same low concentration of multi-arm iodine LX and CPC LX, there is a significant CT signals, and we will need 32 times higher concentration of LX alone to produce the same amount of CT signals. Here, we CT image cartilage samples with varying amounts of GAG contents with multi-arm epi AVAX. First column shows several O staining and showing the spatial distribution of the GAG inside the cartilage explant following the treatment with conjunctivitis. The second column shows CT imaging of GAG-depleted cartilage using multi-arm evidence AVAX. You can see that the CT signals correlates strongly with the spatial distribution of negatively charged GAGs inside the cartilage tissue. This means that we can use this technology for early diagnosis of OA and also for staging different severity of osteoarthritis. AVAX, even at high concentration, did not show any correlation. We are excited about this data and consider cationic contrast agents have great potential in clinical trial. In the future work, because CPC AVAX showed better resolution than multi-arm evidence AVAX, we will try to use higher concentration of CPC AVAX for contrast-enhanced CT imaging, and also build up the correlation between the GAG content and CPC AVAX CT attenuation. Both multi-arm evidence AVAX and CPC AVAX will be used in the longitudinal studies for imaging cartilage using a rat post-traumatic OA model. Finally, I wanted to acknowledge the help from my advisor, Ambika Gajpachi, and the CT technology support from the Julia Charles, the help from our lab, molecular bioelectrostatics drug delivery group, and the funding provided from the NIH.